Good morning. Welcome to another edition of McMaster Perspective. I would like to introduce to you Professor Michael Sharma, who is the medical director of the stroke program at McMaster University, and Michael, the group chair in stroke prevention. So the best person to talk about the stroke, not mentioning the fact that he is also the main author of the stroke chapter in the McMaster textbook of medicine. Professor Sharma, thank you very much for joining us. Maybe I will start from a question. What is the stroke? What we'll be talking about today?
Well, that's a great question, Roman, and thank you for the invitation. It's a pleasure to be with you today. So when we think about stroke, the definition has changed over what it was many decades ago. The initial definition, which was set in the 60s, really talked about duration of symptoms. And if you recall, there was this cutoff at 24 hours. Now that definition was created before we had modern imaging. So the major difference between our traditional definition and the way we use it now is that the modern definition defines a stroke no matter the duration if there is evidence of infarct. And here I'm referring to ischemic stroke. So ischemic stroke is defined as presence of infarct on imaging, usually MRI, but it can be CT as well. And technically, it also allows for pathologic identification if there's an autopsy. Now, there's one caveat to that, and that is we recognize that some infarcts do not show up on MRI. They're usually small, usually in the posterior circulation. And there, we continue to accept persisting symptoms or findings in the absence of imaging. But it really requires an expert to create that diagnosis. I would say that the time-based definition, most often I say, is not stroke. If people are relying on it, then I say, yes, this is genuinely a stroke because of the duration of symptoms.
And when you say infarct, are we talking about pathologically tissue destruction?
We are, and usually now it's defined by the imaging characteristics. So CT scan, you see a hypodensity that the radiologist reads as infarct, acute infarct. MRI, you see diffusion restriction, which the radiologist reads as acute infarct. All of those things really are markers of tissue destruction.
Okay, so I obviously was raised in the old definition. And in the old times, the patient with a stroke was, so to speak, a simple patient. There was nothing to do. Now, it obviously started to change with the first thrombolysis paper and then with clot retrieval papers, but it still generates anxiety: who, when, how fast, and so forth. So if you see a patient who clinically qualifies as a person having an acute stroke, what is your diagnostic pathway? What do you need to do fast? How do you need to think?
Really great question. And let me help you a little bit with the anxiety. And I appreciate that this happens a lot among people who don't do this every day. If you think it's an acute stroke, probably the quickest thing to do is to talk to somebody like one of us and say, do you think this is a candidate for acute treatment? Because even those criteria are changing. So here's what we do. So first off, what we rely on is the recognition of an acute focal process. So if somebody's developed arm weakness, visual symptoms, so they've developed a hemianopia. The time of onset is very important, and that's helpful to establish. The definition of time of onset is last seen normal, and that really drives everything. So for instance, if you went to bed at 10 o'clock last night, and you were fine, you wake up at 7 in the morning and your arm is weak, the time of onset is 10 o'clock last night. So the very first thing that you have to do is, after the clinical evaluation, is obtain imaging. And a universal standard these days for acute stroke is a CT scan and a CT angiogram. Now, the CT scan is critical because externally, no one can distinguish an infarct where you have some acute therapeutic options from a hemorrhage. All we can tell is that there's a focal deficit that localizes here. So the CT scan separates those two very clearly. The CT angiogram lets you know what type of therapeutic options you have. And because all of these responses are time limited, you really want to do those things very quickly. Now, not to add to the anxiety, but in conditions of acute ischemia, we lose about 2 million neurons per minute of elapsed time. So that's why, we push ourselves to be very fast. So the first thing I'd say is if you suspect an acute stroke and you're not an expert at it, is make the call. One of the things that we stroke neurologists have realized is we'd rather be called 10 times unnecessarily than miss the opportunity to treat that one person. And it's usually very straightforward with a physician who just says, I am an internist. I do this occasionally. I need your guidance on this. Now, in terms of timelines for treatment, for thrombolysis, that is 4.5 hours from last seen normal. And if you think about it, you really need to be in this treating center with everything ready, probably by 4 hours to get treatment. If you're there at 4 hours and 25 minutes, the chances that everything will go right in 5 minutes are virtually zero. For endovascular treatment, and that landscape is changing very rapidly as to who we select, the timeline is up to 24 hours from last seen well. Now, within that 24 hours, there are fewer and fewer patients that are good candidates for treatment as you get further out in the timeline. So of the people who present at 20 hours, relatively few of them will be good candidates for treatment. And simply put, what we're looking for is absence of permanent damage and a treatable occlusion. And those occlusions are in the large vessels. So those ones who are candidates for endovascular treatment really have big deficits. They're hemiplegic, they're aphasic, they may have visual field deficits, and they're not ones who are walking with a little bit of dysarthria. However, again, I would say for the non-expert, get the imaging, make the call. That really is the best way to sort these things out. We used to, when we started doing endovascular treatment, mechanical thrombectomy, we used to be very selective and think if the person was disabled beforehand, then maybe they're not a good candidate for treatment based on the trials. But I want to say quite clearly, if you have, let's say, Alzheimer's disease at a mild stage and you are hemiplegic, you can make a good case to treat that person. It makes a big difference if they can walk and talk and feed themselves than if they can't. So I would say in general, our criteria have gotten broader.
Okay, so you did two things. You changed my definition of stroke, and probably you decreased my anxiety level. So let me try to understand a little more. It sounds that clot retrieval, endovascular clot removal, has a longer window at the moment, at least here. You obviously have to have access to it, which is not available to everybody. You mentioned call me, but not every clinician will have it. But if they don't have access to stroke neurologists, they will not have access to clot retrieval. So that will be out of the picture. And it sounds that it's worthwhile to do it until late in the first 24 hours even. So that is number one. Number two, if you are considering, maybe a specific question, if you are considering clot retrieval, how do you deal with thrombolysis? Do you still use it, or do you send the patient for clot retrieval? Where is thrombolysis fitting here?
It's a great question. So I think that the quickest answer to it is thrombolysis we use as if we didn't have clot retrieval available. So the two are used together. One of the issues is because clot retrieval is centralized, very often our patients are coming from another hospital. And again, if you think about what I've said about how many neurons a minute you lose, the earlier you get that vessel open, the better. We have a certain proportion of patients who come to Hamilton Health Sciences for clot retrieval, and the vessel has already opened because they received thrombolysis at their home hospital. And that is perfectly fine with us. Then we don't have to do the procedure. That clot has opened earlier. The only times we will not do thrombolysis are if there's a contraindication to it. The commonest one currently within 4.5 hours is if you are anticoagulated. So if, for instance, you have atrial fibrillation, you're anticoagulated with warfarin or a factor 10 inhibitor, then thrombolysis is contraindicated. With warfarin, you can use it with an INR up to 1.7, but higher than that, you can't do it. So there we'll go directly to clot retrieval. Now, some of the real enthusiasts in the clot retrieval field have said, well, we really don't need thrombolysis. But for the reasons I've said, we haven't moved in that direction. We've had the experience where, for technical reasons, we can't reach the clot with our catheters. And you have a very sinking feeling if you think you've forgone the opportunity to help that person simply by not giving thrombolysis.
Mm-hmm. So say that you have a patient with a stroke in Hamilton General Hospital, and you can go for clot retrieval within next 2 hours. I hear you will give it. You will give thrombolysis. 1
Yes.
hour, you probably would give thrombolysis.
Yes.
15 minutes, would you still do it? Would you prefer to do it at the time of clot retrieval?
So that's a great question. Now, so let me give you the scenario. So we have the patient right here. Our team is free, and the angio suite is empty. So that
unusual,
very unusual. So all the stars have aligned there. If starting thrombolysis is going to delay the procedure, that's one of the rare instances where we won't. So the anatomy is straightforward. So I talked to the interventionalist who says this will be quick and easy. In that case, we'll forego it. More commonly, in that 1 hour, what's happening is the TPA, we now use TNK, which has some advantages, is running while they're doing the procedure, and that is perfectly fine.
Wow. Okay. So you mentioned TNK, which is tenecteplase, right?
Yes.
You mentioned advantages. Some centers probably use TPA. Could you comment on choice?
Yeah. So between the two, we think that TNK is non-inferior. The biggest advantage of TNK is it's given as a single bolus. So you don't need a pump. You don't need the nursing time, the delay to set up and program the pump and get it going. So, you mix it, draw it up in the syringe and give it as a bolus over minutes, and then you're done.
And it's done. Okay. Now, our discussion was prompted by the paper in New England Journal of Medicine. I think it was from out of China,
yes,
in which the question was use of thrombolysis beyond 4.5 hours. What's our approach to it?
So our approach, and the approach at most centers, is we don't do it. What that paper particularly addressed are patients who have criteria that otherwise would result in EVT or mechanical thrombectomy, but they can't get it. So what they did was they said, look, these people have an occlusion. They can't get this mechanical thrombectomy, and we do the imaging. And the imaging that was done was more sophisticated than the simple CT. So they looked as well at perfusion, selected good candidates. And the good candidates are ones where the brain hasn't died, is still viable, but is underperfused. And that takes a little bit of experience to decide. And in those instances, they did show some benefit, out longer than our traditional timeline. Now, the reason we haven't done that is we have access to thrombolysis, so people are to EVT. So people who meet those criteria, we proceed to treat them with EVT and forego the thrombolysis. So I think that it may be of advantage if you're in a situation where you don't have access to EVT, but it does require some experience with imaging to select the best candidates.
On imaging, to pursue it a little longer, because a lot of our audience would not have easy access to endovascular retrieval. What would you look at the CT? I know, as you already mentioned, you need experience and expertise, but what would you look at? I presume clinically you look at some salvageable function still,
Yeah.
and radiologically you look at or for.
So the best way to do it is to use CT perfusion. So CT perfusion requires, in addition to the unenhanced CT, an injection of contrast, and then you can map out. The software is very good at saying this area is not yet dead, but underperfused, and this area is dead. And we have criteria that say if the portion that we feel is irreversibly damaged, is dead, is too large, then you're going to cause problems. So if you think about it, if you open a vessel into an area with dead tissue, the only thing that'll happen is bleeding, right? You won't bring it back. So that is the best way. Now, and it's not that I recommend it, but prior to using perfusion maps, what we did was use something called the aspect score, which looks for early signs of ischemic damage in various areas of the brain. There's a map and a scoring system out of 10, which lets you know how much damage there is, how big the stroke is. Now, the issue with that is, unlike perfusion, where you press a button and it will give you numbers, and with some of the software, even give you a recommendation as to whether the patient is a good candidate or not, that requires a lot of experience. You have to look at a lot of acute stroke scans to do it. And I must admit, to this day, in a room full of neurologists, we're arguing about whether the correct aspect is 5 or 7. So moving to perfusion mapping makes it much more objective, much less dependent on human experience. One thing I will say is people sometimes are frightened about the use of perfusion mapping. We've done it throughout the whole region here. So smaller hospitals have that system. It makes it easier for them even to detect, to make a diagnosis of stroke, because they can look at it and it'll tell them if there are areas of ischemia. So there are benefits to it. It is, in terms of expense, not horribly expensive, but everything has a cost associated with it.
So if I hear correctly, if you have no access to expertise, and if you have no access to technology, it's probably not smart to thrombolyze beyond current window as a default.
Okay. Absolutely. And the guidelines say, please don't do it.
Okay. So hopefully my last question to you is, once we dealt with clot retrieval and once we dealt with thrombolysis, antiplatelet treatments down the road, what's the current wisdom here?
That's a great question. So if the patient has had thrombolysis or clot retrieval, we don't use antiplatelets for 24 hours and we do a scan thereafter. If that's not the case, and currently we're acutely treating something like 25% of our patients with thrombolysis, clot retrieval, or some combination of the two. So the majority of them don't have hyperacute treatments. If that's not the case, and the CT scan shows no hemorrhage, then we like to get antiplatelet agents started right away. Now, the major differentiator between when you use dual antiplatelets or aspirin are two things. First is time. So dual antiplatelets are best used in minor stroke or TIA within the first 24 hours. There's some data to suggest that you can go out to 72, and the guidelines will say you might consider it up to 7, though I think that's based on
7 days.
Yeah, not a lot of data, 7 days. I think the safest thing that I can give is to say consider dual antiplatelets for 72 hours. And the difference is in how you judge how big the infarct is. So neurologists, we will use the imaging to look at and say, well, this looks large or small. Again, that takes experience. What we've written in the guidelines and what was done in the trials for non-experts is the NIHSS. So dual antiplatelets are a good choice if you're within 72 hours, best if you're within 24 hours. and the NHSS is 5 or less. So there, the risk of hemorrhagic transformation is low and the benefit is there. We continue dual antiplatelets for a total of 21 days. Trials of longer duration really haven't shown more benefit, but they do show more risk for bleeding. So 21 days is fine. And I must honestly say that the bulk of the benefit seems to be in the first 7 days. So if I have a patient who's having nosebleeds or complaining about bruising, and they're a week, 10 days later, then I will go to single antiplatelets. If
And
you have, if you have a larger stroke or you're outside that window, then aspirin really is the therapy of choice. Get that in quickly.
and dual antiplatelet would mean?
For most people, it is aspirin and clopidogrel, which decreases the risk of stroke recurrence over aspirin alone by about 25%. Now, one of the issues with clopidogrel, of course, is it needs to be metabolized to its active form. And there are a certain proportion of us who do not have the enzymes that let us metabolize that drug. In Caucasians, that's maybe 20 or 30%. In East Asians, it may be as high as 60%. So a few trials were done replacing the clopidogrel with ticagrelor, which is widely used in cardiology. Doesn't need to be metabolized. There aren't any genetic barriers to that. I must say, the results of those trials suggested an effect size about the same as clopidogrel, maybe a little less to our surprise. And there was an increased hazard of bleeding. So the default right now still is clopidogrel for most of us. We will use ticagrelor if the patient has a stroke on clopidogrel or for some reason can't tolerate or use it, then ticagrelor, knowing that there is a somewhat increased risk of bleeding.
So to summarize, in a relatively minor stroke, within 1 day, maybe 3 days, possibly 7 days, you would go with 2, of which the second usually by default would be clopidogrel on top of aspirin. If the stroke on the NIH scale is larger or more severe and the timing is going away, you would go simply with aspirin.
Absolutely. And the candidates for that longer term probably are patients who have atherosclerosis causing the stroke. So you see it in the carotid or intracranially. And again, that would require the imaging and that expertise to consider it. And the guidelines will say only consider it. It's not a strong recommendation.
Okay. And it would be for, and dual antiplatelets would be for 3 weeks effectively.
Absolutely.
Professor Sharma, you decreased the level of my anxiety to a considerable degree. I'm in fortunate place where I can always call you, so I will be less anxious about calling a stroke neurologist. And I think I understand the timing and criteria a little better, and I hope that our listeners as well. I thank you very much, and I'm looking to the update of the stroke chapter in McMaster textbook.
Thank you very much, Roman. It's been a pleasure.
It was for me as well, and I learned a lot. Thank you. Goodbye.
Bye-bye.